Okay, so it's a pleasure having you all here with this live webinar, this European group in APD, and we will be recording this and uploading it to the YouTube channel of a master program for APD that we are running here at the Aristotle University of Thessaloniki, Greece. Let me see. Okay. I'm just going to share with you some of the things that we are doing in the European group of APD, just really focusing on some key elements on this systematic review and meta-analysis of questionnaires used for auditory processing, screening, and evaluation. And this is a joint effort with scientists, researchers, and clinicians from different European countries. Obviously, this will be a very short introduction, but the whole article is online, and I will be sharing later on in the chat the link for you to read and elaborate on the details. Now, we have this recent report of the World Health Organization on hearing auditory processing disorder, defining it as a distinct clinical condition that degrades hearing capacity. And it further goes on to acknowledge that the existence of APD could be throughout the lifespan with the possible negative impact on mental health. I'm sure we all know that pure tone audiometry is the gold standard for assessing hearing, but still it is not enough if we are talking about challenging acoustic environments. And this report emphasizes the need for evaluating central auditory function in cases of mild hearing loss, as well as in individuals with normal pure tone audiometry results. Now, just to say a few things about this systematic review, we found out that APD individuals consistently exhibited worse scores compared to healthy controls across all questionnaires. As you can see from the flowchart, only a few studies diagnosed APD with what most scientific audiology societies globally report as sufficient criteria. So we had a lot of studies that were either using undiagnosed population or mixing populations diagnosed and undiagnosed, and then thinking that this is one group instead of two or maybe many more different ones, especially in the undiagnosed category. So we ended up with only 12 studies that we could analyze due to this fact. And you can see that we came up with 6 questionnaires and 783 participants in these 12 studies. And one of the things that were the conclusions is that the need to use and report subscores as well as overall scores of questionnaires, so as not to miss on information that is already there and may be important. And the second need is for more focused research on APD diagnosed individuals, because obviously if more studies had this diagnosed criteria already in place, we could have more data, and thus the results would be more robust. Now, going beyond the systematic review, we feel as a group that there is a need for common ground in hearing evaluation, and this should not be based on self-report as a standalone tool for hearing evaluation. And the need to state this comes from multiple publications that rely on self-report alone to report on hearing capacity. And this obviously results in many misunderstandings. We could say that the minimum APD battery could include speech in noise or bubble at multiple signal-to-noise ratio levels to extract the 50% correct items identification, a dichotic digits test, and a temporal resolution one. Now, Professor Frank Music, a huge and well-established researcher and clinician in neuroaudiology, will be lecturing today on the need for electrophysiology to be included in the diagnostic process for hearing evaluation, keeping in mind that this hearing evaluation includes hearing sensitivity as well as auditory processing. And now I will give it over to Professor Tai Van for a short announcement of the upcoming World Congress on Audiology that he will be hosting in Paris in 2024.
Thank you, Vivian. I am very pleased and honored to announce that Paris will be hosting the next World Congress of Audiology. You can jump to the next slide, please. And that will be the opportunity to tackle many different topics, covering cognition, complex auditory disorder with ANSD, hidden hearing loss, auditory implants, hearing aids, but also vestibular disorders, also tinnitus and hyperacusis. And there will be plenty of room there for discussing our matter of interest, processing disorder, and the link between auditory processing disorder and learning disorders like dyslexia or developmental language disorder. So I just wanted to give you a hint about this major event that I will be very pleased to organize with my colleagues in France. And that will be just 2 weeks after the Olympic Games in 1 year, starting on the 19th of September. I hope you will be there. And Frank, it's up to you now to deliver your talk.
Okay. All right. Well, thank you. And
I will just stop sharing. And Doris, could you make the introduction because we are very well acquainted, to say the least.
Okay, I hope that it will not be too noisy. I'm at a friend's place in Athens. Frank was my supervisor of my PhD, together with Linda Laxon, that we sadly lost on Saturday. And I feel ever so lucky. He was one of my, with Linda, he was the most definitive person in my career. Obviously, he's a pioneer in audiology and in central auditory processing disorders. He's received so many awards. I think the last one was the Royal Archmason's Gold Medical Award for Outstanding Research on Central Auditory Processing Disorders. More than that, he's trained or interacted in a way that shaped thinking and research and clinical practice with the majority of people who are active in auditory processing disorders and in other areas of audiology. And beyond all that, he's an ever so nice person. He's very fond of ice cream. That's what I remember. I'm not sure if that has changed over time. And he has a lovely, lovely family and a lovely, very supporting wife, Sheila, who should really be attending this as well and talking with us. Without further ado, I'm looking forward to hearing his presentation. Thank you so much, Frank, for everything you've done over the years.
well, thank you, Doris, and thank you, Vivian, and your group for inviting me here this morning. And even though it's early here, I think I'm wide awake, so I think that we can get started. And I certainly look forward to the meeting in 2024 in Paris. That sounds like it will be a very interesting and timely meeting. So I hope that I can attend that. I guess that I have to go to share screen first. Here we go. I think this will work. And let's see here. All right, can everyone see that?
Yes,
Am I
that's great.
okay? And so I guess we're underway. I want to again just extend my thanks. I'm going to do a presentation this morning that is just a little bit different than what I usually do. And I think it reflects some of the times that we are in audiology, especially in the United States, and maybe not so much in Europe. But I think that it's appropriate for us to sometimes, those of us who work on the developing different types of diagnostic procedures, as many of you have, and as many of you that I'm talking to this morning use, we're always looking for the next best procedure to evaluate hearing and auditory processing, or both of them at one time. But I also have to believe that, given what I have learned over the past decade or so, is that audiology has actually turned us back on some very valuable procedures that have not been given their due and perhaps have been exited too early in their time with us. And I'm going to talk about those this morning. Again, referring more to the United States, but we certainly have not made or taken advantage of some of the most powerful procedures that we have. And so what my lecture is about this morning is more of a persuasion, not necessarily to the group that I'm talking to now, but to other groups that may view this presentation, that we need to take a look retrospectively at some of the procedures that I feel we just are not using to their full capacity. And that's kind of my direction this morning. So it's a little bit more of a persuasive talk than it is highly data-driven talk. So, but we have some data in there. One of the things that I wanted to mention, that when I look at your website, I really think that this is a great byline. And I think everyone that does audiology should look at this and think about it, because I think this is just something that I've strived for the last 40 some years. And that is auditory processing tests, or those of auditory processing of neuroaudiology, should really be included in some version or some capacity in everyday audiological evaluations, because without this, one is not really evaluating the entire auditory system, which is what is our responsibility to do as good clinical and research audiologists. However, before I go into my little discussion this morning, I wanted to, I guess my opening comments will be lacking without mentioning the passing of Professor Linda Luxon, who was, of course, Doris's mentor and worked with her for so many years. Linda was an icon in vestibular research, an outstanding clinician, wonderful teacher, and highly supportive of CAPD. However, more than that, she was a wonderful, friendly, and compassionate person. She will be missed in many ways by many people. And I wanted to just be sure that I mentioned that about a great friend and a great colleague. All right, so part of my title is Back to the Future, and that's kind of what we are, because I think in some cases we actually have to look back to look forward appropriately. And I've picked a couple of procedures that I've done some work with, and when I look back about what is happening to these procedures and other diagnostic procedures, including those of central auditory processing. Now, as many of you know, but many people don't realize, that really one of the biggest diagnostic procedures that we have today is actually central auditory evaluation. It is a diagnostic procedure and fits under this category. However, though I'm going to mention that today, I'm going to talk about two other, which are actually central auditory procedures, because the central auditory system is predominantly involved, and that is the auditory brainstem response in combination with the middle latency evoked response. This is the reason why I have been driven to become very vocal as much as I can about the need for looking more closely at diagnostics by audiologists. And this is from the United States, but this is from Medicare data, which primarily, I have to say, deals with adult patients. But this is the outcome of over 1 million evaluations that have been reported. And I thank Barry Freeman for directing me and helping me with some of these statistics. But what you see happening, at least in the United States, is that we've become kind of a one-trick pony. We certainly do audiological evaluations, but beyond that, we are not doing a whole lot. If you look here, the circle kind of encompasses the diagnostic procedures, which are all well under 10% of the reports of these over 1 million evaluations done by certified audiologists in the United States. So you can see plainly why I am concerned, and as are other people concerned about the fact that we may be losing one of our strongest components of audiology, and that is our ability to do diagnostics to help with the evaluation of those patients with otologic disorders, as well as neurological disorders and perceptual disorders, such as children with learning disabilities. So this is where I'm kind of coming this morning to talk to you about my persuasion to go back to the future, so to speak, and start using these powerful procedures more than what we have. So I'm kind of directed in terms of the red box here, is that there is no question, at least in the United States and perhaps even in Europe, that diagnostics have been diminished. And one of the reasons, obviously, but not the only one, is that imaging has become an all-go-to type of decision-making procedure. And though it is extremely valuable, and I don't want to say that it's not, it is a key in terms of diagnosis. I think, as you will see, I think it's maybe overstepped a little bit more than what we really maybe should be using it. And also, sometimes we don't recognize disorders that really do require ABR or MLR or central testing in order to make a diagnosis, and that is an audiological diagnosis. I think there are too many people that don't recognize some of these disorders that are very amenable to using such procedures as the auditory brainstem response and the middle latency evoked response. So getting into this, actually ABR can be complementary to imaging in many cases. And one of the things that we are running into, and I'll show you this in a minute, is that ABR, I think, can reduce what I see and a lot of people see as over-referral for acoustic neuromas, or better labeled, I guess, vestibular schwannomas. Also, I wanted to bring out some current research on the utility of the ABR MLR in multiple sclerosis, which again, I think is overlooked. And also how, in fact, in some cases, you can pursue imaging when maybe the audiogram And symptoms of the patient do not necessarily indicate that. And we'll talk a little bit about that. So let's talk about this idea of over-referral, which actually is quite, to me, eye-opening. And that is one of the key factors, of course, as you all know, is that if you have unilateral hearing loss that is sensory neural, it is a primary sign to consider acoustic neuromas or schwannomas. But we also have to realize that the vast majority of individuals with unilateral hearing loss do not have acoustic neuromas. And you can see here that it's actually less than 1% to about 7.5% based on a systematic review that individuals with unilateral hearing loss have acoustic neuromas. So you're talking about a very small percentage of the population. And in another study, and this was an eye-opener and certainly not the only one, where only of all these referrals that have been made without ABR consideration being done in the clinic, yields only a little over 1% of positive findings. So no matter how or where your healthcare system works, there is still finances being expended to do these procedures, which can amount to a tremendous amount of money and impact with very little yield. If in fact we step in with an ABR, these over-referrals can be cut considerably. And I think this is an important thing to do. I think we have perhaps been too sensitive to the power of imaging without considering this tremendous amount of over-referral for things such as acoustic neuromas based on symptoms and unilateral hearing loss. So the other thing that I wanted to talk about is that the use of ABR and even MLR in multiple sclerosis. So the interesting thing is that the prevalence of multiple sclerosis is growing and growing because these individuals, especially in current medical care, have almost a normal life range. So they are accumulating a prevalence. And in the United States, we now have well over 1 million cases. And as you can see here, Europe and North America are the most populous in terms of the prevalence of multiple sclerosis. And in fact, the ABR and MLR, especially in combination, can yield a pretty good sensitivity to multiple sclerosis. And one of the studies that was done a while ago by Bob Levine and his group at Eaton Peabody Labs in Boston was kind of an eye-opener. And I think sometimes we forget about the sensitivity of this. And if you look at this study, in fact, what you see here is that, let me just move this here for a minute. Though they only tested 16 patients with confirmed multiple sclerosis, they did extremely high quality MRIs on these individuals to look at exactly where the plaque was in the pons. And of these 16 patients, 12 had no lesions at all, and these all had abnormal ABRs. However, 4 had auditory pathway lesions and all had abnormal ABRs. The upshot of this study, which was a very important one, is yes, it doesn't have big numbers, but what it shows is that when there is a lesion in the auditory pathway, and these people looked at this extremely closely anatomically, is that the ABR is probably going to pick it up. And when it's not there, it's probably going to be normal. Now, a lot of the statistics reported on MS and ABR and even MLR don't take this into consideration because often these lesions cannot be isolated anatomically as well as they've done in this study. And in many cases, when you take a general population of MS, most people may not have lesions of the auditory system, but when they are there, it's extremely important to pick them up. And I think that we've haven't done ABR a good service by considering this. A recent study by Gure also showed that 12 out of 13 studies on MS people showed positive ABR results. All right, so another study that that I think is important is, or the consideration is, that audiologists need to consider are the symptoms of a patient with multiple sclerosis that comes into your office. You have to consider whether, in fact, it is a peripheral problem or a central auditory problem, because MS could exist in both places. That is, peripherally, it can, of course, affect the auditory nerve, which is peripheral, but it also probably has a greater tendency to affect the central auditory pathway, including not only the brainstem pathway, but obviously, especially the corpus callosum, which is primarily all myelin. So the importance here in terms of managing patients, it is important to determine whether or not it's a peripheral problem or a central problem in terms of best management of the patient. Now, the DiStadio study, which is one that I'm going to refer to now, is interesting because it relates to sudden hearing loss. Now, most of the time and over history, when an individual reports to an otologist, audiologist, neurologist that they have sudden hearing loss, the first consideration, of course, is that it is some kind of cochlear insult or possibly even auditory nerve insult. But one of the things that has to really be considered here, especially based on the DiStadio study, is that it may be MS. And here you see that in this study, which was a meta-analysis, is that 92% of cases of sudden sensorineural hearing loss occurred early in the history of the disease. So it's an early way of perhaps picking up what may be early signs of multiple sclerosis. And in the female patients in this study, okay, almost half of them, this was the only symptom that first appeared, that it was not a visual symptom as often is reported, but in fact, in this particular meta-analysis, 50% or almost 50% of the female patients, not as many in terms of male patients, this was the only symptom that first occurred. In these cases, as I just had alluded to, 60% and 40% respectively of the plaques were in the brain or internal auditory meatus respectively. This is not startling, but certainly is important information in terms of the occurrence of where these MS plaques occur. And finally, this is the one that is really critical, and that is all ABRs in this meta-analysis that were done on these individuals with sudden sensorineural hearing loss were abnormal. And even after hearing had improved, the ABR remained abnormal. So we need to have perhaps a closer look at this and maybe more studies done along this line. But this study should open all our eyes to the fact that we can't always consider the cochlea as the only cause of sudden sensorineural hearing loss, or even acoustic neuromas, of which is quite rare. But we have to enter into that analysis or options. We really need to consider multiple sclerosis when we see sudden sensorineural hearing loss. So here's a case that we had. We actually have seen 3 cases in my clinical experience on sudden sensorineural hearing loss and being multiple sclerosis. This is a case that we saw a number of years ago when I was at Dartmouth. And this was a lady, a young lady, I think in her late 30s, who driving home one day started to notice ringing in her left ear. And shortly after that, she began to lose her hearing in that ear and also had some unsteadiness and imbalance problems. Interestingly, over the next, she made an appointment, but came in several days later. And at that point in time, she said that her left ear had recovered somewhat, not totally, but somewhat, still had tinnitus. Balance problems were not quite as bad as they once were, but she was able to navigate and walk okay. But she came in and gave us this audiogram, which probably indicates some recovery of the left ear. So in looking at this, and at that time, we thought the first thing, again, as most people, that this was a cochlear insult of some sort. But interestingly, we decided that what we would do is to pursue an ABR anyway, because of some other indications. And this was the ABR, which you can see is for the left ear at 90 and 80 dB NHL, highly abnormal, with wave 5 way out in the 7 millisecond range and a very poor morphology compared to the right ear. And so this is what opened up our eyes, Center for an MRI, which showed the plaques in the brainstem area. So that was one of the cases that we had seen. This leads me into another comment that I wanted to make to everyone out there, and that is this opens the door to the idea of combining the auditory brainstem response and the middle latency evoked response, because both of these procedures are relatively good in terms of picking up individuals with auditory involvement in multiple sclerosis. So here you can see is just a diagram that I put forth to show you the combination of these two. Putting them together really saves a lot of time, and it gives you an evaluation of not only the auditory nerve and brainstem pathways, but also the geniculate cortical connections for which the middle latency evoked response, the NA and PA waves especially, can be sensitive to. It is efficient. It gives a lot of information about more of the auditory pathway. And as many people have said over the years, going way back to Scherg's report, our report, and Krause's reports in the early 80s, that this is a strong consideration for clinical use to evaluate more of the auditory pathway than just the ABR. And so here's some data. Again, if you look at this, some of the sensitivity isn't overwhelming, but you have to remember, just as in other types of disorders, the auditory pathway is not always affected in MS, and therefore you don't see extremely high hit rates unless you can verify where the actual plaques are anatomically. But here you can see some relatively good findings, and especially if you look at the asterisks, you see where the combination of the ABR and the MLR can yield very good sensitivity to these individuals with multiple sclerosis. And therefore, the combination, I think, of this is something that has not been given its due. It needs to be used more, it needs to be researched more, and clinically applied more. Now, the other thing that I wanted to mention is that, at least in the United States, we have this tendency to look at things such as acoustic neuromas or MS in terms of unilateral hearing loss. Well, depending on who you read, there are a fair number of people that have various kinds of problems in terms of auditory sensitivity, or not a problem with auditory sensitivity, that have considerable clinical involvement. So many times when we look at a normal audiogram, we say the patient's fine and pass them on. Excuse me, let me get a drink of water here. And so what's happening here is that we have a tendency without an ABR to look at a normal audiogram, even despite sometimes symptoms, and pass the patient on. Yet if the ABR was abnormal with an audiogram, which does occur in acoustic neuromas and certainly in MS, we would have more of a tendency to pursue imaging. And there's a great article by Edwards and Kalani back in 2003 that profiles this particular kind of situation where in cases of symmetrical hearing loss or normal audiograms, patients are passed on or not looked at sufficiently. And with an ABR, an abnormal ABR, of course, this would direct the clinician to pursue further evaluation, and in these cases, even imaging. So having done that, I wanted to then talk a little bit more about disorders for which ABR and MLR, I think, are front and center. And maybe imaging is not that useful. And I've outlined just a few here that I'm going to spend a little bit of time on and maybe show you some cases as to why this is happening. Well, obviously, one is ANSD, auditory neuropathy, which cannot really be diagnosed without the use of ABR. Hyperbilirubinemia, which I differentiate from ANSD, mostly on an anatomical basis. Heavy metal neurotoxicity, concussion or mild head injury. And we also have to remember that there are also many patients that cannot, probably 1 or 2 out of 100, that cannot undergo MRI because of claustrophobic tendencies. So, or various kinds of metal devices that they have implanted. So there is a room and a very important basis for looking at a greater use of ABR MLR. Most of you understand this and know this. I won't spend a lot of time, but in terms of ANSD, incidence is kind of hard to determine because there are a lot of different ways people look at this. But probably about a little under 2% of the pediatric population, if in fact you separate hyperbilirubinemia from ANSD, which I feel it should be, but that may be an argument for another time. But most of the time, you will see about 70% of the time an absent ABR totally, or in almost 90% of the time, according to Sininger's work, about 90% of the time, the ABR will be abnormal. I still ascribe that if, in fact, you are looking at ANSD, one should preferentially look at the possibility of a totally absent ABR. A present cochlear microphonic, of course, is important. Hearing loss can be variable from normal hearing to complete loss. And so that cannot be a really good guide. Absent acoustic reflexes, as you can see, 84%, and present OAEs with hearing loss beyond what one would expect in about 3/4 of the cases. So here is a case, here is some data just to show you or remind you that the idea of ANSD really requires, by audiological means, the use of ABR in order to make the diagnosis. Without ABR, the diagnosis, I don't believe, can really be accurately made. One of these one of the types of disorders that certainly falls into adult auditory neuropathy is Charcot-Marie-Tooth syndrome. And I hearken way back to 1982, where we published either one of the first papers, if not the first paper, to implicate the auditory system in Charcot-Marie-Tooth, which at that time, back in and before 1980, really was not considered to have any auditory or hearing correlate. So I wanted to just hearken back and show this paper from back in 1982. This was a 55-year-old secretary, executive secretary, who was actually about to lose her job because she could not understand dictation and she could not well communicate with the people in her office. And though she was highly efficient and very talented, she was about to lose her job because she simply had a very difficult time communicating. And this came on, rather gradually, but over the recently a year and a half or 2 years. And this was her audiogram, which you can see is not too bad. It's actually pretty good, especially in the left ear. But if you look down below here, you see that as we raise the speech recognition level of presentation from only 30, which is a typical, to plus 50, the speech recognition scores drop dramatically, which of course was one of our first considerations. And now we know that Charcot-Marie-Tooth syndrome actually does have an audiological correlate, and maybe up as many as 30% of patients with Charcot-Marie-Tooth may have auditory problems or hearing loss. Here is this patient's acoustic reflex data, and you can see here a couple of things that I think are kind of interesting, and that is, first of all, there is no response at a couple of frequencies or elevated at other frequencies, but in fact that the sensation level is really reduced despite the fact that they have almost complete acoustic reflex decay. This, of course, indicating the correlate to recruitment, and this one indicating just the opposite. And you can see this in both ears. So kind of interesting findings there. We also did central tests on this patient because at the time we did not know what we were dealing with, where we were dealing with a central auditory problem, some type of neuropathological problem of the central auditory system, or what. So we did our central auditory test battery, and this is from 1982. So there's some tests there that we don't use anymore, but some that we do. But look at the scores. You can see in this profile that both ears are down, left worse than the right. Across the board, there essentially is a lack of any, except maybe for one, for the right ear, the test being normal. Pitch patterns and filtered speech were almost impossible for this lady to do. Masking level differences were also below the norm. So this was tracked down. We worked with neurology and found a family history. This lady's uncle also had Charcot-Marie-Tooth syndrome, and this was one of the first cases ever reported, and one where ABR, MLR, and central test played a big role. This was her ABR, essentially no response, that was readable, regardless of many different trials that were run. So again, an eye-opener to show that a true adult auditory neuropathy from Charcot-Marie-Tooth syndrome, where ABR central tests are indeed valuable. Hyperbilirubinemia, which is primarily, as we know, related to jaundice that gets out of control. And this is just a report on this particular disorder. And here you can see a recent report that we have from 2016. And you can see the ABRs are, again, the central conduction time are abnormal. Absolute latencies are significantly extended. The 1-3 and the 1-5 intervals, as you can see on the right panel of the screen, are also highly abnormal. So hyperbilirubinemia, which I differentiate from ANSD because the jaundice, hyperbilirubinemia, or in later stages, kernicterus, primarily affects the brainstem pathway, specific affinity for damaging the cochlear nucleus and not necessarily the auditory nerve. In these cases where auditory nerve is involved, I would argue it is because of retrograde degeneration of the cochlear nucleus. And therefore, I like to differentiate hyperbilirubinemia from ANSD. And as I say, that can be a discussion for another place. But again, to point out an important fact, and that is in hyperbilirubinemia, ABR becomes extremely important and valuable because imaging really is not a big help. Heavy metal exposure, lead and mercury exposure, again, there is a correlation that have been shown in a number of studies where ABR has extended latencies of waves 3 and 5 and are correlated with high blood levels. And most people that have done analysis of individuals with heavy metal exposure would argue that ABR is perhaps the best procedure for picking up dysfunction related to lead or mercury poisoning, and certainly should be in the front line of consideration for evaluating these people, along with, of course, the appropriate type of medical chemistries that should be done. Here is a case that actually was a relatively famous case because it ended up being on the news in the United States as well as in all the newspapers. And it was a case that we were involved with when I was at Dartmouth a number of years ago. But this was a very, how shall we say, well read about case in the United States. It's a professor of chemistry who was doing research on mercury in their entire career. And all of a sudden, one day, this individual started to experience, believe it or not, auditory problems. They began losing their hearing and also started to incur some vestibular symptoms. Because her auditory problems were front and center, and the first one she noted, they were sent to us. And this was the audiogram that I obtained from this lady. And you can see again, the audiogram is not too bad. But if you look over here to the right panel, you see that spondy thresholds and speech recognition could not even be assessed because she could not understand any of the words and really had a hard time communicating with us. And this was quite early on. So we communicated primarily by writing, but though she had relatively good sensitivity, her speech recognition was terrible and indicating severe damage of not only the periphery, but more so the central auditory system. And here you can see her OAEs or DPOAEs, which are essentially normal and a little better than what you'd expect based on the audiogram, which of course is a diagnostic indication. And over on the right panel here, you can see an ABR that is essentially just devastated with hardly any kind of response. And especially at relatively high rates, you see that the ABR is in shambles and totally absent in the left ear. So this is a case that was written up because no one could figure out how this individual, who was very well versed in handling mercury, became poisoned with it. And there was a lot of speculation in all the papers, and we were involved in this particular case, which was written up in here and hearing. And getting towards another particular disorder for which these procedures as well as central testing can be valuable is in mild head injury or concussion. And the most common ABR abnormality that we see in head injury is a 1 to 5 extension of the ABR. And there are a number of studies, as I'm showing you here, where about 50% of the cases do show abnormality. But again, just like in MS, individuals with head injury or concussion, it does not always affect the auditory system. So therefore, sensitivity of the ABR is very difficult to get a clean and objective and accurate view of how good the procedure is. I can tell you by looking at a lot of individuals with head injury and require various kinds of neuropsych testing, that a 50% hit rate is pretty good for various kinds of auditory tests, because of the fact that often auditory system may not be involved in head injury. And in many cases, as you see here, the MRI or CTs really are not that valuable over, generally speaking, the population with these mild types of head injury. But again, the ABR may be. And Nina Krause's group has also reported speech FFRs with a much higher than 50% hit rate. But I think that probably should be replicated. But I wanted to mention that, as she does show a very better hit rate than what I'm showing you here. And perhaps we need to take a close look at that also. But again, mild head injury, concussion, when these people come into the audiologist's office, it's important to realize that there's a 1 in 2 chance that auditory system may be involved, and this is going to require testing beyond the pure tone audiogram. So this is an interesting case that we saw along the way that speaks to head injury. This is a 29-year-old that was in a car accident and actually was in a coma for a couple of days. Came out of the coma with and had a number of orthopedic problems, which were attended to and got her attention when she awoke. But after a couple of days, she began to report that she had tinnitus in her left ear. She had extreme distortion in that left ear and hearing difficulties in that left ear, especially when compared to her right ear. So she was evaluated at the hospital, and this was her audiogram, and evaluated. This was actually an audiogram that we had copied from the hospital, and she was released and sent home without further evaluation, despite the fact that she reported tinnitus in her left ear, as well as hearing loss and distortion, especially compared to the right. So again, this is a situation that happens all too often, where in fact the audiogram looks good and everybody thinks the hearing's fine, despite the fact that she did have a left lateral pontine contusion by neurological evaluation. So if we go beyond the audiogram with this head injury, we find that the contralateral reflex were absent on the left, but normal on the right, normal temps, both ears. And look at this ABR. Well, the ABR in the left ear is essentially missing probably wave 5. It looks like a hint of wave 4 there, but here we see abnormality of the left ear compared to the right ear, which is consistent with the patient's complaints. She came in to see us about a month after she went home, complaining of the same problem she complained about in the hospital. And interestingly, if you drop the intensity of the ABR, as you see in the lower panel here, the left ear, which is on the bottom, the ABR essentially disappears. And this is why for years we've recommended, probably even in diagnostic procedures, a 2-intensity evaluation using the ABR. This is why. All you have to do is just pick a couple of central tests. And here we just did a couple or 3 of them, and look what happens. If you just take one step beyond the pure tone audiogram, this really opens your eyes, because the left ear is essentially on these tests non-functional. And this is a rather drastic and dramatic finding, again, consistent with the patient's complaints of a left ear problem despite a normal audiogram. A 4-minute procedure using digits would have opened the eyes probably of any audiologist, but in fact, that step has to be taken in order to best evaluate these kinds of patients. So, in summary, we've gone through what I think are a retrospective view of the past, but looking into the future, and that is that we need to perhaps take a closer look at the ABR and MLR and central tests in terms of evaluating these people that come into the clinic. The days of looking at just a pure tone audiogram is not what is necessary in our present environment. And I've tried to persuade, and I don't think I need to persuade probably this audience, but probably many people who won't be tuning into this or watching it, that we really need to convince our colleagues that, in fact, like with one of our opening slides, evaluations need to be done that include electrophysiologic as well as behavioral testing of the central auditory nervous system, because there are too many cases, with more of them evolving day by day, that require this kind of evaluation, or the actual auditory deficit will not be uncovered. And I think to that, we do a disservice to our patients, and we can do, I'm telling you, much better. So let's go back, let's pull out, go back and look at a broader use, a more in-depth use of the ABR, MLR, as well as, though I didn't talk about much today, the central auditory test components. Now, in closing, there are two other procedures that I simply don't have time to talk about that, again, I think have been overlooked. And one of them is maximum length sequences, where we can do high rate ABRs and MLRs in a very quick time, stressing the auditory system and uncovering cases where I think there are central deficits where ordinarily we might not. MLS, or maximum length sequences, has not been given its due. And it's something, again, we maybe need to take another look at. And the other one is binaural interaction components, or the BIC, for both the ABR and the MLR. And for those of you that aren't familiar, we're going to just talk about this one very briefly. And as most of you know, the BIC in 1980 was made quite popular by a number of people, including Bob Dobie and Chuck Berlin and other people that did work on it, including ourselves back in the 80s. But then it was kind of dropped. It really didn't pick up much clinical use. And here is, again, combining our ABR and MLR. And you can see in the left circle here, what happens is that when you combine these two, the left and right ear responses, and compare it to a binaural stimulation, you get a difference. There's slight attenuation of the binaural over the right and left ears combined yields what is a BIC, or binaural interaction component. And when you subtract one from the other, you see this kind of waveform. And this happens for waves 4 and 5 and 6 of the ABR, and also for the NAPA wave for the middle latency evoked response. So this is argued to be, and I think appropriately, is a binaural interaction at the brainstem, and now even at the higher cortical levels, which indicates a binaural processing that appears that is not in a lot of patients with different types of pathologies where the disorder has kind of compromised appropriate binaural processing. And some studies that have been done with the idea of using the BIC as a clinical marker, I would applaud, and I would say this is another procedure we need more research and more clinical use with. And I just reported a few studies here, as you can see below. The BIC is correlated with intraoral timing differences, as you would expect. And that's a strong correlation in a number of studies. But ABR has been shown using the BIC to be reduced in auditory processing disorders in terms of amplitude, the middle latency also. And a study by Pratt at Eaton Peabody Labs a number of years back also showed that in pontine lesions, the BIC is severely compromised in a high number of these patients. So though I can't talk much about them, I would certainly support, again, bringing back some of these procedures such as MLS and the BIC for us to take a closer look at electrophysiology and the central auditory nervous system. And it looks like I'm probably a little bit over, but that wraps it up. Thanks a lot for listening. And certainly I will entertain questions if Doris, and I think Helen is going to help me with handling these questions. So again, thanks for listening.
Frank, that was an excellent lecture. Thank you ever so much. And I was thinking, listening to you, that how important timing is in the auditory system. And obviously that imaging does not give us information, or conventional imaging does not give us information about this timing. And how satisfying it is to use tests like ABR in the battery that we use to assess our patients. I have a case, a next case that I will probably ask you about, but I'd like to ask the audience if they want to either raise hands and ask the question verbally, or if they want to send a question in the chat that I can read out, or Frank can read and reply. So over to the audience. Is there a question, a comment? Well, maybe I can open this in that case until people prepare their questions. I had an MS lady who actually sought me out because she had auditory difficulties. And what was interesting, the difficulties were predominantly with degraded, distorted, or fast speech, problems with speech in background noise. And actually, she said foreground seems to be the same with background. Probably she read that somewhere, but that's what she was feeling. What I found interesting was that when I did the APD assessment, the speech-based tests in noise and in competition, including the dichotic digits, did not pick up anything. But what was abnormal was the gene, the gaps in noise, which was at 8 milliseconds in both ears, and response was consistent. She had some slight ABR abnormalities, but I thought they were convincing because the ipsilateral recording, just wave 1 was poorly repeatable, but the contralateral recording, waves 3 were absent. And I think 5, I can't remember now if it was poorly, reliable. And the only other thing was that in her imaging, there were some subtle changes in the pons. And we looked at this case with Tim Griffiths and Jason Warren in our joint clinic when I did the tests. So I explained this on the basis of the ABR abnormality that were consistent with the imaging and the gene. And of course, I sent here for neurocognitive psychology, but would you have any comments about this? Because I thought that I would find ABR to be a little bit more grossly abnormal in this case. So do you think that's a justified explanation of her presentation? And of course, as I said, I'm awaiting for neurocognitive assessment as well.
Well, Doris, yeah, the question you pose is one that is not unusual. I do think that, well, I just have a couple of comments. The first comment is simply that if one takes a look at the ABR, remember we are only testing a certain anatomical region of the auditory system. And again, it depends so much on the anatomy of where the actual plaques are. And there can be very mild invasion of the auditory pathway that may yield these kinds of results. And then at a later date, it may become more involved. But I do think that the particular case that you described is one that is amenable to at least my thinking about the anatomy of multiple sclerosis, and that is it depends to what degree and where those plaques are located in terms of the sensitivity of what the test is going to be. Now, if you step back for a second and look at the ABR and a procedure such as gaps in noise, which is a temporal resolution procedure, those are actually both timing tests. The ABR is no more than an electrophysiological representation of high synchrony of the auditory brainstem pathway. It is a test of synchrony, which in any hearing science book, they would tell you is simply a timing processing procedure. And so therefore, you would expect to see some possible correlation between those two. An 8 millisecond GIN is abnormal, but it's just barely abnormal. So I think again, a lot of this has to do with the subtlety of the lesion and of course the sensitivity of the test. But I think you're going to see an entire range of different kinds of findings with this MS population. But I think that the importance of following these people, and certainly I'm sure that you'll be following this person, things may crop up and show at a later date to confirm these very subtle findings.
Okay, thank you. Are there other questions, comments from the audience?
Okay, I'm not hearing anything, so may I contribute as well? And everyone feel free to write something in the chat if you would like. I really appreciate the survey on audiology procedures that you saw us in the beginning, that I was wondering how this might be more pronounced, the fact that we are using less ABR techniques, less electrophysiology in general, or less OAEs than behavioral testing. How might this be even more pronounced if we take into account the fact that in most clinical practices we use this as a screening mode, in a screening mode. So to be quick in the clinical practice, many of us use an automated ABR and the screening protocol in OAs, which is obviously not producing so much information if you want to really elaborate in for diagnostic purposes. What is your thought on that?
Well, I think that Jim Jerger used to say and told me that, sometimes audiology is pushed into a corner where, in fact, they are very time compressed, and therefore they feel that they have to do tests that take up a little time. And certainly that's where I think a lot of the screening tendencies seem to come from. But I think that there are cases where we really need in-depth analysis and where screening is going to obviously fall short. And therefore, I think that we owe it to the patient to do the most appropriate and as best we can evaluation on them, which sometimes means that we have to go beyond screening. However, having said that, and again, going, Vivian, more to your question, is that let's take a look at screening. I mean, why not do the procedures such as, and I've said this for years, you all know this, that the dichotic digits test takes very little time. And now, you know, there are a number of people that are working on the GIN as with a screening part. And I think those can help direct us in the right way. But we have to get out of the periphery and we have to look at something that can evaluate the central auditory nervous system, which is an extremely complex system, as you all know, requiring extremely complex analysis. And, you know, the digits and some of these quicker procedures perhaps can be used in that way, but that step has to be taken away from just looking at the periphery and looking at the central system. The other thing that I mentioned, of course, was the maximum length sequences, where those can be done as quick as you can hook the patient up. The MLS, you know, you can do an ABR at 700-800 clicks per second. Can you imagine how many evaluations you can do in 2 minutes using MLS? And certainly what has been published by in the literature is that it's more sensitive than the regular ABR. And that's, again, one of the reasons why I had mentioned it even so briefly in this report. I just think that, yes, screening can be done, but I think there's a time and place for everything. And I'm not sure that in some of these cases, we do have to go beyond screening. But if we screen, we have to screen for something that is sensitive to the central nervous system as well as the periphery. I'm not sure that best answered your question or not, but those are my thoughts.
Well, thank you. That was very elaborate. Thank you a lot.
May I ask a question? Bill Keith here. Thank you, Frank. That was a thoroughly interesting presentation. And I know that you teach those of us who specialize in APD that if we keep at it, we're going to see these cases which are neurological, and that has certainly proven true for us. And we're in the middle of testing someone now, a 10-year-old, and it looks like it might be auditory neuropathy spectrum disorder. The left ABR is abnormal. It pretty much disappears at a high click rate. The speech ABR is similarly abnormal. But and we haven't finished doing all our assessments, but what's interesting to me is that there are no acoustic reflexes at all. So even the ipsilateral reflexes are absent on both sides. So from what you're saying this evening, does that mean, sorry, this morning for you, would that make it more ANSD than hyperbilirubinemia? Would you expect to see ipsilateral reflexes present with hyperbilirubinemia, and more likely, if they're absent, it would be ANSD?
Well, Bill, first of all, nice seeing you again, and thanks for your comment. And you raise an extremely important issue about hyperbilirubinemia versus ANSD. The classic studies, and I'm going to answer this anatomically, the classic studies, and then I'll go back to the audiology that you have. The classic studies in humans were done by William Dublin, a neuropathologist, who for many years studied hyperbilirubinemia, jaundice, and of course, kernicterus, and has wrote a book about it and a classic paper in 1986 that an entire issue of Archives of Otolaryngology was devoted to. And what Dublin showed, which hasn't been shown since, because of the fact that we control it so well, you know, in terms of these babies do not die from kernicterus like they once did. But in Dublin's days, going from the 1950s to the 1980s, he was able to do pathology on the brains of these individuals that died from kernicterus. And I can't tell you how important those studies are, and yet they are overlooked by so many people. And what Dublin clearly showed was that in hyperbilirubinemia, the auditory nerve was not affected. Absolutely not affected, and nor was the cochlea. But what was devastated was the cochlear nucleus and the inferior colliculus and on up into the thalamic areas of the brain, which are extremely compromised in these pathological studies, okay, in humans. Unfortunately, those papers that were widely published in the 70s and 80s were overlooked by so many people that have done work on kernicterus and ANSD. The gun rat model is only a model. Gun rats don't get hyperbilirubinemia. So there is a real problem with looking at some of the animal data and trying to compare it. So anatomically, hyperbilirubinemia is a disorder of the central auditory nervous system, and that has been shown pathologically extremely clearly in humans. I think, as most cases, animal studies have to be taken with a grain of salt, where in fact hyperbilirubinemia is induced in these jaundice rats. Yes, they are valuable, but they are not as valuable as the Dublin studies on humans. So anatomically, that's where I'm coming from in terms of the differential. And that's why I like to make that difference clearly. Now, in terms of separating those, in your particular case, the first thing you have to look at is, in fact, did the particular patient, in this case, what was a 10-year-old, was a diagnosis of hyperbilirubinemia or jaundice ever made? Because if it was, even early on, even though with light sensitivity and therapy, it does not always negate the fact that the auditory system can be damaged, and that damage continues. When I was at Dartmouth and at UConn, we saw not a number, but a fair number of patients that had high bilirubin levels at birth that were treated, but years later came to our clinics, just like yours, with APD, and were diagnosed by using ABR and, you know, a central auditory test battery. So it is very difficult. I would disagree with Berlin and even my good friend Linda Hood on some of these cases where you have low brainstem involvement. It is very difficult to differentiate by ABR whether it is auditory nerve or the cochlear nucleus or root entry area in the cochlear nucleus. And therefore, I think you have to depend on the medical diagnosis early on of whether hyperbilirubinemia was actually diagnosed. And if it has the profile, it certainly could be that, or it could be, yes, auditory neuropathy. But I think that in some cases where, in fact, wave 1 is present and the ABR is abnormal after that, I would lean heavily against it being ANSD. One of the problems that we have in the United States is anytime many audiologists see an abnormal ABR in an infant that indicates central involvement, they immediately call it ANSD. And the reason they do that is because they don't have a good repertoire of these other disorders that can affect the brainstem, low brainstem especially, and not be ANSD. So I would argue very strongly that there is a difference between these two, and that difference, I think, needs to be investigated more. The paper that was published in 2003 by Isabel Rappin does a service to this and brings this whole idea out about the difference of the fact that ANSD is not a common disorder. As you know, some of our people who do research argue, well, it's very common, meaning, 5-10%. They argue that it just isn't. Now, some of you remember Isabel Rappin. She is one of the few auditory scientists who was a neurologist, okay, by training. And, she argued in that 2003 paper, which was an excellent paper, that one, it's quite uncommon and is often, that is ANSD, often confused with problems of the low brainstem. So I would direct you to that paper, and I guess that I've talked enough about that. But if you want to follow up, Bill, I'd be glad to answer a sub-question you have. Oh, I can't hear. Yeah.
Thanks. That's very helpful. We might be in touch if we can sort it out. Thank you, Frank.
Are there any further comments, questions? Hung, I see that you've unmuted.
Yeah, actually, so thank you first, Frank, for your outstanding talk again. It's very funny that you just mentioned the confusion that may exist. So considering the fact that ANSD is a spectrum, I can tell you that at least in continental Europe, there's still some debate about the fact that should we consider ANSD as a central disorder or not. And some colleagues also raise the point that when you have to deal with a given patient diagnosed with APD, it might be the case that this particular person may have been diagnosed as ANSD when he or she was younger. So we all know that the outcomes of hearing aid fitting or even cochlear implantation in ANSD subjects is very diverse. According to you, would it be contributive to perform the whole APD test battery for any ANSD subject to be able to have some prediction about what his or her outcome with hearing aid or cochlear implant would be? Is there any room for doing that in clinical routine, according to you?
I do think that, especially when you're considering cochlear implantation, or it could even be brainstem implantation, depending on the situation and what's going on. I think the only way we are going to be able to better clear up this differentiation may be by doing additional test procedures and either looking at correlations between things like the GIN and the ABR and other kinds of central auditory test procedures that maybe we haven't even developed yet. But a lot of audiologists, and I've talked about this with a lot of people, and that is they say, well, Frank, what difference does it make if they have an auditory nerve problem or a low brainstem problem? And because, we're going to treat them all the same. Well, right now we are treating them all the same. And that's one of the reasons why we see the tremendous diversity in outcomes of our implant patients. At least that's what I think. And what that is that's a very non-scientific approach to it. If we don't try to learn more about the differentiation of this disorder, because physiologically and anatomically, let's face it, the auditory nerve does very little compared to what the brainstem pathway does in terms of processing auditory stimuli. And therefore, I think it is important to differentiate those two, because I think not only perhaps in terms of cochlear implants, but for other things in terms of managing the patient, it may become very important to find out whether the brainstem is involved and not the auditory nerve, or vice versa, or perhaps in some cases both, because there's no question, as Kent Moress has shown in a number of animal studies, there is retrograde and anterior grade degeneration in the auditory system, and one area can contaminate the other. But remember that there's a big difference between the auditory nerve myelin, which is, Schwann cell generated, versus as soon as you get into the brainstem, where it is oligodendritic myelinization. And these types of myelinization are susceptible to different kinds of disorders to different degrees. And so there is a difference there. And I think if we can't turn our backs on this potential difference. And I think the way that we need to investigate it is just what you've alluded to, is that we need to start looking carefully at how these different test procedures are yielding different kinds of results, because without this, we'll never become any smarter.
Thank you. That really makes sense. Thank you so much.
Anything else for today? Oh.
Well, I think, thank you again, Frank. This was a tour de force. And I'm sure you've convinced several more people today about the need to include ABR and other electrophysiology procedures in their assessment battery. I'll refer to Vivian, who can close this session. And of course, the session is recorded and the slides have been shared.
Well, thank you very much for the invitation. I enjoyed it, and all the best to you and all the great work that you all do, and especially to your APD group, which I think your opening byline is is really a good one about we need to start looking at central tests as part of a battery of tests that need to be done on most all patients. So again, thanks for the opportunity.
Thank you for spending the time here and for making us all look into things in a different way. Of course, we keep saying that we need to include central auditory tests, but we should find a better way to implement this. So hopefully we will do much more work in the future. Thank you very much all for being here and for participating, and especially thanks to you, Frank, for sharing all your knowledge, a part of it with us. I think it was a very nice webinar.
And we'll see you in person in Paris.
Exactly.
Good. Yeah, I'd like to come to that. Keep me in mind. Sounds like a great time.
We will for sure.
Okay, with that note, we're closing this.
Thank you.
Thank
you
you.
all. Bye.
Thank you all. Thank you all. Bye.
Thank you.
Goodbye.
Bye. Bye.